Uh, Hello, this is Dr. Ayub. I'm going to start the rest of the pathology lecture on the female reproductive system, and especially on I'm covering the uterine part. Today I will cover the benign uterine neoplasms. Okay, so benign uterine neoplasm will be covered today. Let me take out this piece of writings here, and let me take out this part. Okay, so from the benign uterine neoplasm, and there is a malignant uterine neoplasm. So let me start from the benign first. So this is neoplasm, the solid tumor, and is a cancer in nature. Sonographically, we need to be very aware about the characteristics, sono appearance characteristics of the benign and the malignant part. So today we'll discuss about both benign and the malignant. So neoplasm is the new growth. So new growth, mostly it is a solid type, and it could be benign and it could be malignant. And we will understand the characteristics of the benign nature. We will understand the characteristics of the malignant nature. That is the sonographic characteristics. Okay, let's talk about the benign part first. Let's start with the Nabothian cyst. If we understand that the anatomy of the female reproductive organ okay, so this is the uterus, and this is the vaginal part, and this uterus has a fundus, then body, and then cervix, CX, and this is vagina. So these are the typical parts of the uterus and the vagina. And as we know that there are two fallopian tubes they arise from the fundal level, and it communicates with the uterine cavity and the pelvic cavity. So this is uterine cavity. Okay, so these are the fallopian tube. There are two. We are going to talk about the Nabothian cyst. Nabothian cyst is present at the cervix because Nabothian glands are present in the cervical region. And this Nabothian gland produces lubricating fluid or cervical secretions that goes down through the external os into the vagina. Okay, so now the Nabothian gland is present in the Nabothian yeah, in the cervical region. So let me draw the cervical canal, and I'm drawing the Nabothian gland. For your better understanding, I'm drawing this diagram. Okay, so now this is the Nabothian gland. Nabothian gland. And this is duct. So Nabothian gland produce the fluid, and this Nabothian gland produce secreting fluid, lubricating fluid, and this lubricating fluid goes through the duct into the cervix, then it comes to the vagina. Okay, so now if I draw more, you will understand that this lubricating fluid is a fluid, it's a liquid, and it gives the anechoic appearance in sonographically. This Nabothian gland is smaller in size. Normally sonographically we cannot see it, but due to any cause that the duct of the Nabothian gland is obstructed, due to any cause, due to inflammation, due to polyp inside, due to any stricture, any compression pressure, the Nabothian duct is compressed. As a result, there will be backup of the fluid. There will be backup of the fluid, and the fluid will go into the cystic area, into the glandular area. So as a result, when it goes into the glandular area, then what's going to happen? There will be backup, and there will be anechoic area, and is bigger. Now you can see it. Okay, so now we call it Nabothian cyst. And this Nabothian cyst is common. A certain group of people, and it says that it is found in the young age group and also in the childbearing age group. Sometimes you can see also postmenopausal, but it's very rare. And this Nabothian cyst could be singular, could be plural, could be bigger size, could be small size and medium size. And sometimes the Nabothian cyst could be very close together, looks like a big one cyst, but they are separated. Sometimes this Nabothian gland can be infected, and formation of pus inside, exudate inside, and patient will complain severe pain if somebody touch the cervix, and patient will complain pain during biological activities. Even though when there's a multiple cyst not yet infected, still during the biological activities it will be painful. Okay, it will be painful. And the most common cause that I told you, that is a blockage of the duct, but most of the time it is asymptomatic. incidental finding. So then what is the problem? I'm going to say no problem. But there is a problem. When it gets bigger. What? It can produce the pressure effect, patient will feel pain, and it could be such a big one that it can cause obstruction of the cervical canal. Because of the pressure effect, it can cause failure of the sperm to move forward towards the uterine cavity. So that can cause infertility. Okay, so this is very important. And also if it is big, very big, and during the delivery of the baby, it can cause a problem. Okay, and most of the time it can be spontaneous rupture, then it's fine, before unless they have to do the surgery. Okay, and it says here the cysts are asymptomatic and pose no risk to the patient, and it can be at any age of a female, and the adult, mid-age female, and postmenopausally they said it's more than young age group. Okay, so postmenopausally it is more common. Maybe it is associated with some hormonal estrogen, progesterone. Okay, it could be associated, but nobody knows the exact cause. Okay, so now this is Nabothian cyst. When there's a multiple Nabothian cyst, you will see only the cystic area, then no ductal dilatations can be seen sonographically. Okay, so now I will draw the sonographic image, and keep that in mind. These are the simple cyst. Simple cyst. Okay, you might see one is here, another is there, another is there. Okay, it is a simple cyst, and it produces the edge refracting shadow, and it will produce enhancement, posterior enhancement. And it is completely anechoic. Posterior enhancement is brightness, completely anechoic inside, and its wall is very thin and small. Okay, so that's the way you will see the Nabothian cyst. Now question, do I need to measure? I'm going to say if there's a multiple, measure the only bigger one or the biggest one. If it's a single, measure it. Why? We need to follow up in the next time when the patient comes for the exam. We will follow it up. It is going bigger or not, and where is it located? Is there any chance of compressing the cervical canal or not? Okay, so this is Nabothian cyst. Okay, so that's all for the Nabothian. Now I will talk about the leiomyoma. Leiomyoma, another name of the leiomyoma is simply myoma or fibroid. So these are the benign neoplasm of the uterus, and it arises from the middle layer, that is the myometrium. Okay, the etiology is 20% of the women over 35, they develop these tumors. Okay, 20% of the women. That's why 20% is a 1/5 of the woman population. They have it. It may present with symptom, most of the time asymptomatic. It could be single, multiple, different sizes and different location. The incidence is higher in the black population, that is African woman, and myomas will grow in the presence of estrogen. Keep that in mind. Myoma, before menarche, myoma is not there. Teenage myoma is not there. It is estrogen dependent. And when the estrogen level is high, at what age group estrogen level is high? In the child fertility time, right? Fertility time. And when the pregnancy, the blood circulations goes up before pregnancy, and during pregnancy the hormone estrogen, progesterone goes up, and this myoma will grow during that time bigger. Okay, so we are going to discuss about the leiomyoma. We call it fibroid. Or simply myoma. It is a benign tumor. As I said, it is a benign tumor, and 20% of the woman population over age 35, they have it. They may have with the symptom, without symptoms. And they are highly estrogen dependent and higher vascularity dependent. And the estrogen dependent happens during the pregnancy time, and the fibroid grows bigger during the pregnancy time. Why? Because the hormones are more, and the food, nutrition, that is the circulatory systems, they supply a lot of blood with oxygen and nutrition to the uterus for the baby, and the fibroid share that food. That's why it grows bigger. That's why sometimes we see that where is the fibroid, or how many are them, where they are located, because they will grow bigger and they will occupy the endometrial space, uterine cavity. So baby may have IUGR, baby may not reach full term, maybe there will be miscarriage, uterus may not like it, they will expel the fertilized egg. Okay, so a lot of things can happen. So we need to understand this situation. And you know what is IUGR? Intrauterine growth restriction. Okay, the baby may be smaller, baby may be smaller symmetrical, baby may be smaller asymmetrically. Okay, so this is not very compatible with the life. That's why we need to think about it. And if the fibroid, if found that it's growing bigger after menopause, it doesn't look good. It is not a good news. Any fibroid that is growing bigger after menopause, so most of the time we say that those women who has fibroid, they are 5 times risky group for the malignant. And if a fibroid after menopause suddenly grows bigger, we presume that it is turned into malignancy. So this is very important, keep that in mind. An woman postmenopausally may not have dysfunctioning uterine bleeding normally, but patient develop DUB, dysfunctioning uterine bleeding. We have to consider that it could be a neoplasm. It could be neoplasm of the endometrium, it could be neoplasm of the myometrium, or it may be a fibroid turned into malignancy. That's why follow-up is very, very important. At least once in a year, the follow-up of the old fibroid. Are they, or is it going to be involuted or getting expanded? It is very important. We need to follow up any growth of the fibroid, any growth. Okay, so now we'll talk about the etiology, clinical signs, symptoms, location, and sonographic appearance of leiomyoma. So the etiology that I said, that nobody knows the exact cause. Sometimes it runs in the family, as it is hormone dependent. So hormone variation can be a cause of fibroid too. Okay, so and as I said, it is higher in African women. And the clinical signs, symptoms, I'm going to say it could be asymptomatic. Okay? Clinical sign and symptoms. It could be asymptomatic. Means unnoticed, asymptomatic. And it could be symptomatic. What could be the symptomatic? What could be the symptoms? So patient may complain of pain, mostly cramping pain. Especially during period, during menstrual period. And then the heavy bleeding. We call it menorrhagia. Heavy bleeding, menorrhagia. Patient may come with anemia. Because of the too much bleeding, patient will have anemia. And anemia means weakness, fatigued. Okay, so this is the most common. Sometimes patient may come with severe pain due to torsion of pedunculated fibroid. We'll talk about it. And patient may have pain also due to necrosis, ischemic pain, because if the fibroid is trying to grow bigger but the enough food and oxygen are not available, patient may develop ischemic pain. Okay, so sometimes pain due to necrosis. But this is emergency. This is emergency. Patient has to go to the hospital. They may need for surgery. Okay. So now, what is the other symptoms? Patient may need for metrorrhagia. Patient may have metrorrhagia. Patient may have frequent micturition. Frequent micturition means frequent urination, and patient may have bowel obstruction because it can compress the rectum posteriorly. The frequent micturition happens because when the fibroid is anteriorly, it can indent the bladder and the bladder capacity will go down, and a small urine collection in the bladder, patient feel like they need to go for micturition and they go bathroom frequently. Okay, so these are couple of things, and last one, the palpable mass. Patient feel like palpable mass here. They feel it because when there's a multiple fibroid in the uterus can be enlarged and they can feel it. Sometimes if there is a pedunculated fibroid arising from the fundus, they will be in the false pelvis, and sometimes patient can feel it. And beside all this, patient may have a generalized pelvic pain. Generalized pelvic pain. Okay, so now I will talk about the location of the fibroid. Okay, I will draw here the location. So location, it could be subserosal, interstitial, we call it mural. Submucosal, that is under the endometrium, and pedunculated.